Thank you, Gaurav. Before I proceed to my presentation, at the outset, I would like to thank the AIOS Management Committee, especially Professor Namrata Sharma, who has again revived this Armed Forces Special. We all know that it was, we used to have Armed Forces Special, and long back it was stopped, and I always had a desire that we were not getting enough representation in this platform, so I pushed for it, and henceforth they have all promised that in all the national and international conferences we will have a special armed forces session. And again, on 10th and 11th of May, we are going to have Armed Forces Special, which will be done through the aegis of AIOS in Armed Forces in Army Hospital RNR. It's a platform basically for my younger specialists who are posted in periphery, who do not get a chance to come to the main forum and present their cases. It'll be a two-day session. We are trying to take it up with Office of DGFMS to get a officially recognized, and you can come on temporary duties. Rest all the details will be shared in the Service Ophthalmologist Forum, so that you present. We'll have case presentation, we'll have video presentation, and you will have the awards will be given to the winners. So I look forward for more participation from our younger colleagues, and it'll be a good platform for them. We'll also have live sessions, in the sense learning sessions. So we'll be MIGS and all. We'll try to get them hands-on training on those. So with that, I start my presentation. That is the experience of Brolucizumab in Army Hospital R&R in diabetic macular edema. So this is basically a presentation of the RCT which was done in Army Hospital R&R, and further observation of DME post RCT and other novel applications of Brolucizumab. We all know that FDA had approved 2 doses of ranibizumab, that is 0.3 in DME and 0.5 in CNVM. And again in Kestrel trial, which was done, Kestrel study, which was done, this drug was used in 2 concentration, that is 3 milligram and 6 milligram. We divided these 2 groups. 2 patients were divided, one receiving 3.6 milligram of Brolucizumab, another 6 milligram of Brolucizumab. And we took all the necessary clearances, ethical clearance was taken, and it was registered with CTRI. Inclusion criteria, basically we include all those cases who are treatment naive, no history of PDR, and BCVA of less than 0.1 logMAR unit, and CMT of more than 300 micron on SD-OCT. Anybody who received treatment or PDR, any treatment in form of anti-VEGFs or laser were excluded out of this study. So this is a different study, because normally the trend is to use loading dosages in DME. In fact, loading doses can be 3 to 5 loading dosages. But we went ahead with this on a PRN basis right from the beginning. 4 weekly interval from week 0 to week 28. And BCVA was measured at each visit using logMAR chart, and the central macular thickness was measured. Safety parameters was given a very, very special mention and special precaution, because we were always looking for any adverse reactions. So patient at day 1, day 7, day 21 were examined thoroughly for any evidence of IUI. So any patient on visit, when there was a presence of IRF or SRF on SD-OCT, was given re-injection. These are the retreatment injections criteria. Any reduction of BCVA of 0.1 logMAR unit, or thickness increasing to more than 350 micron, irrespective of any IRF or SRF. So the ocular adverse effect were graded from grade 0, that is no adverse effect, to grade 4, which is of most importance, is grade 4, formation of hypopyon or any vitritis more than grade 2. So these are the results. Both the groups were evenly matched as far as the ocular and the other parameters. And if you see this box and whisker chart, the vision has improved from 0.74 to 0.12 in 6 milligram Brolucizumab group, and again 0.735 to 0.25 in 3.6 milligram group. This is the table form, and again this is the charting of 6 milligram group. Again, 3.6 milligram, improvement from 0.74 to 0.27. This is in the chart form. And this is what is the changes in the CMT in 6 milligram brolucizumab group. It improved from 371 to 273. Again, in the same 3.6 improved significantly. So the number of injections, 6 milligram group received 119 injections, and 3.6 milligram group received 112 injections. If you see the number of injections, the requirement has gone down from week 0 to week 28. The ocular side effects, 6 milligram group, there were grade 3 ocular AOI in IOI in 4, and in grade 4 or in 1 case. These cases, grade 4 case was managed well with PST and oral steroids and recovered to the pre-injection vision. And again, this patient was again given brolucizumab with no reaction again. In 3.6 milligram, grade 3 in 3 and grade 4 in 1. One word of caution that, this IOIs need not present on day 1. It can happen in your 3rd injection, in your 4th injection. So every time you give an injection, please follow your patients very carefully. And you have to tell the red flag signs to the patient that with these red flag signs, they have to immediately report back to the center. So these are other interesting facts that HbA1c dropped, probably because the patient became more aware of the diabetic status and had a better control. And group 1 had 13.6 presence of SRF, and group 2 had 16.7. So the take-home message is that brolucizumab is an effective form of therapy in the central involving DME. It can be used in a lower dosage, that is 3.6 milligram. Just remove this thing, timer. PRN basis can be employed right from the beginning. We don't have one speaker, so we have little extra time. PRN basis can be employed right from the beginning. It's again against the norm normally what is being followed. Patients usually require 3 injections over 28 weeks on an average, and adverse effect, if at all present, is manageable. So these are the 2 landmark studies what we did. This is very important to tell you that when this drug was launched in India, there was a lot of apprehension. Even RP Center was apprehensive to use this drug. So as Armed Forces always does, we took this challenge straight away head on. And we started our study. We gave this as a thesis topic to Srishti, and this was a study which was published in the International Journal in the neovascular AMD when this drug was compared with aflibercept. And this is the study which is published this year, that this is the topic what I was talking about, that's been validated now, that it is, you can use a lower dosage of this drug, and you can use PRN therapy. All these studies, one should formulate your own strategy. You need not follow the same convention what has been published. So this, now since this is published, it becomes a new convention that you can treat these patients on a PRN basis. So now we have this RCT data complete over 104 weeks in neovascular AMD, and we have seen the inter-injection durability of 12.6 weeks is achieved as compared to 11.3 at 52 weeks data. And it can be used in subset of PCV also, though it is slightly less effective as compared to other indications. So it works in PCV, it works as well as aflibercept, longer inter-injection interval. But I say that it is the PCV durability is lesser as compared. This is the data where in neovascular AMD, the brolucizumab group received 94, and in the aflibercept group received 180 injections. So till now we have used more than 2,000 injections of brolucizumab, which is probably one of the highest in the country. And we have used this, taken beyond the conventional indications like myopic CNV, where the convention is to use ranibizumab. And in RVOs, and earlier they were said RVOs, it's a contraindication to use in RVOs. We have started using in RVOs also, and other novel uses. So this is the case of a myopic CNVM. This is at 28 weeks. The patients received 2 injections and remained asymptomatic since then. So other indication like angiomas, von Hippel-Lindau, they usually bleed a lot when you do a vitrectomy. and normally you give anti-VEGF before doing vitrectomy, and the bleeding was much better as compared to the ranibizumab, and the surgery was completed successfully. The subretinal, this is very important, the subretinal TPA injection, normally in cases of submacular bleed post CNVM, we give TPA and brolucizumab in the same dosage subretinally. Normally you use aflibercept or ranibizumab, we have used this, and this is the surgical video. This is a one-eyed patient, had a old, if you see this white lesion, that's an old bleeding, and had a fresh bleeding next to the old bleeding. And this patient was given a subretinal TPA as well as brolucizumab, and finally recovered to 636 vision. Thank you.
Thank you, Sanjay. Groundbreaking data, excellent study. I think this will be replicated by most centers. The volume of data is huge.